Okay, we could ask everyone to take their seats, please. Okay, welcome back, everyone. We're going to continue with our focus on healthcare by exploring the effectiveness of accountable care organizations in driving healthcare value. The discussion will be led by Dr. Julia Logan. Ms. Logan is the Chief Medical Officer for our CalPERS clinical programs and appeals. Welcome, Dr. Logan.
Thank you, Mr. Jones, and welcome back from the break, everyone. In a very short period of time, ACOs have become an important and widespread part of the U.S. and California healthcare landscape. An ACO at the most basic level is a group of healthcare providers that accept responsibility for care for the health needs of a defined population while meeting predetermined quality benchmarks. The specific goals of ACOs are to improve quality outcomes, improve the experience of care, and lower costs, also known as the triple aim, which should improve the value of the healthcare delivered. And it's important to recognize that this definition is relatively broad, and there are many different types of ACOs in California and nationwide. It is also interesting to note that ACOs are actually relatively common here in California, and California leads the nation in the number of ACO arrangements. Given the promise of improving value in healthcare, CalPERS has been a leader in pioneering ACOs and actually encourages our plans through the plan contracts to expand their use of these payment arrangements. Despite their rapid and widespread adoption across the country and in California, relatively little is known about how ACOs actually work and how successful they have been on a large scale. This is due in part to their relative newness, as many ACOs are just getting up and running. Others have been operational for short periods of time and have yet to produce meaningful or long-term results. CalPERS was involved in one of the first, in fact, which is also one of the largest commercial ACOs. The evaluation of this commercial ACO by CalPERS staff was recently accepted in a peer-reviewed journal recently, so we're really pleased about that and hope that this publication and research can add to the body of knowledge we have about ACOs. This presentation this morning will help fill some of the void we collectively have around these ACOs and help us answer some burning questions like, have ACOs fulfilled their promise on delivering on value, and what the future looks like for ACOs in our state and in the healthcare marketplace. We have brought together two very knowledgeable people about the subject to help us answer those questions. First, we have Dr. Cheryl Damberg, who will provide an overview of ACOs in the marketplace. This review of Medicare ACOs and commercial ACOs will include a description of the variety of ACOs, their evolution, and their impact on value. Then, we'll have Dr. David Cowling speak. Dr. Cowling is an Assistant Division Chief here at CalPERS and leads the Health Information and Pilot Performance section. He will be providing an overview of the CalPERS experience with ACOs, including the Sacramento ACO created in 2010. After Dr. Cowling's presentation, we'll be hearing back from Dr. Damberg, who will round out the presentation with some thoughts on evidence of success and challenges to success moving forward. With that, I'd like to formally introduce our first speaker, Dr. Cheryl Damberg. Oh, can I give your bio?
Oh, sure.
Dr. because it's very impressive. Dr. Cheryl Damberg is a national expert in the areas of pay-for-performance and value-based purchasing applications of performance measures, physician and hospital performance measurement, measures of cost efficiency, and evaluating the effects of performance measurement systems and alternative payment models. She's leading a 5-year, $17 million AHRQ grant to study the evolution of health systems and identify factors that contribute to high performance and adoption of evidence-based practices. Previously, she served as a director of research for the Pacific Business Group on Health. where she led early efforts to measure the quality of provider organizations and report comparative performance results to consumers, and was a research fellow in the U.S. Department of Health and Human Services. Dr. Danberg received her PhD from the Pardee Rand Graduate School and an MPH from the University of Michigan. And with that, I'd like to pass it over to you.
Great. Thank you for having me here today. It's a real pleasure. And I want to thank Suzanne Delbanco for setting up much of what I'm going to talk about today. So I'll just say ditto to many things that Suzanne already discussed. So what I am going to do is to talk a bit about why ACOs and what they are and what they're supposed to accomplish. And then I'll pass it to David to talk about what's been learned from the CalPERS work. And then David's going to pass it back to me, and I'll talk about what we know about ACOs more broadly, and then leave with a few concluding thoughts. So why are we kind of thinking about ACOs and some of these other types of strategies to improve quality and cost performance in the healthcare system? So for those of you who may not be sort of aware of the history, the Institute of Medicine, now called the National Academy of Sciences, published a very influential report in the year 2000 that really outlined the serious problems with the American healthcare system and talked about the various interventions that were needed. And this particular report, Crossing the Quality Chasm, followed by another report, To Err is Human, that focused on patient safety events, really crystallized for a broader community how bad our healthcare system was functioning, and really allowed people to come together and have conversations that they weren't previously having. And what this report really identified was that change was needed. And I think as purchasers of care, whether it was my time at the Pacific Business Group on Health or when I worked for the Department of Health and Human Services, I think there was, this common refrain of why are we paying all this money for lousy care? And what is it that we can do to try to encourage providers and the organizations in which they work to try to fix these problems? So as Suzanne outlined, we have been trying to evolve the payment systems in the United States. And despite our efforts to really put pressure on changing pay to move toward the right-hand side of the screen to pay for value, we are still operating in a predominantly fee-for-service world. Over the past 2 decades, we've experimented a lot with pay for performance and are now in this new space around paying for value. The early pay for performance experiments focused heavily on rewarding providers who delivered better quality of care without considering what the underlying cost was. And so this shift to pay for value really focuses on trying to look at both aspects, quality and cost. And as Suzanne noted, and I think David also underscored, fee-for-service operates as follows. You go in for a doctor's visit, they're going to write down a bunch of codes on a piece of paper that they then submit to the insurer. And you're essentially paying a doctor for every service they provide. And there's no recognition of whether it was the right service for you, so it could be inappropriate care, it could be care that leads to a safety event. And so this is where our current system is heavily dominated at the moment. So paying for value, as I mentioned, really tries to push providers and the system toward having financial rewards, having the underlying, what I'm going to call financial inducement for delivering services, really be mindful of cost and quality. So where do ACOs come into this picture? As I mentioned, there are a whole host of strategies being implemented try to affect this value proposition. And one of the central strategies that has been promoted over the better part of the past decade is accountable care organizations. And I like to think about them as a three-legged stool, where you are bringing together the payer with the providers. In some cases, that can just be a physician group. It can be a hospital-run ACO that has providers along with. But ideally, it encompasses all three parties at the table. And this is really a strategic partnership. So while historically there has been what I call a financial partnership through contracting mechanisms between the payer and the providers, this extends that type of relationship in a deeper way, and I'm going to show you how in a few minutes. But these ACOs are built on existing payment mechanisms, or chassis as I call them, and that can either be an HMO type model where there's already very explicit accountability for populations, or it can be built on top of a PPO model where there's looser accountability. So how does an ACO model, or conceptually what are we talking about here? So in terms of what you see on the left-hand side of the screen, the ACO contract components, is that within the context of the contract, there's accountability for financial performance. That's a big piece of these ACO contracts. But there's also accountability for quality measurement, and in order to really promote better care, there's also accountability for data sharing. And it's not just sharing of data from the provider up to the health plan, but something that not everyone may appreciate is that the health plan also controls a lot of information about the patient that the individual provider does not have. So things like pharmacy information or information on hospitalizations. And so the idea is if you get that information flowing in both directions, one can have better management of the patient. There are also various other factors that come into play in terms of the structure of ACOs, in terms of the provider group characteristics, in terms of their patient population, their health IT infrastructure to know what's happening to patients. And then sort of layered on top of that are a set of interventions. So if you're going to manage a population of patients differently, that requires some new ways of delivering care, some new processes, and new ways of communication. And this is all with a goal to achieve the things on the right hand of this slide. So several of the presenters already mentioned that right now in this country we have about 32 million lives that are in ACOs, both those through commercial insurers as well as through Medicare and Medicaid. There are more than 1,000 ACOs. And what I'm going to show you in a few slides is that all ACOs are not created equally. And so when you think about whether they're having effect, you really need to think about how they're structured and designed. So as I mentioned, ACOs are supposed to drive a number of changes. So better data sharing between the payer and the providers, better coordination of care as patients transition, say, between the ambulatory outpatient setting into the hospital and then back into the community. They're also supposed to try to minimize waste and duplication of services that can often occur when people don't share information and know that a test was already delivered. And they're also supposed to be accountable for managing populations and what the totality of care is for those populations. So let me give you a couple of examples for the types of things that ACOs are doing. So one of the areas that ACOs have tended to focus on if you're going to manage high costs are managing patients with complex medical conditions. And so instead of just having a primary care physician interact with the patient, what they're trying to do is build a constellation of support around the patient that extends beyond just the primary care physician, and to have these players work in coordination, in concert, to fully manage that patient. Similarly, around transitions in care, This requires a lot of coordination. It also requires formal discharge planning. I don't know if anybody has been to the hospital lately, but if you're discharged now compared to when you might have been discharged 10 years ago, they're providing you documents, they're scheduling follow-up appointments, and they're making sure that you don't fall through the gap when you are sent home. So what is the evidence on ACO effects? So just to note, as we think about what the research studies are showing, most of the evaluations that have been done to date focus on Medicare and all of its variants of ACOs. There's only a handful of studies that are on commercial ACOs, and David's going to talk about the CalPERS experience, but a lot of the evidence to date has really come out of Massachusetts, and that's a very unique model, and I'll talk about that more later. So as I see, when I look at this landscape, and I have been approached by private plans to actually conduct ACO evaluations on their behalf, a critical issue here is around what I call transparency. There's a reluctance, particularly among the commercial payers, to have their interventions studied and the results disclosed. And that's in part because if the results are not favorable, shareholders will not look well on that. So I think we have to collectively, if we're going to try to push this market forward towards improvement and a better understanding of whether these interventions work, we would like to have better transparency. And this is an opportunity for us to improve these models so that they succeed. The other thing to note when you think about trying to understand whether it's an ACO model or any other type of intervention is what is the savings you're comparing to. And I think as you look across these different studies, you have to be very careful to understand what's the right counterfactual. So that's sort of a techie research term, but you need to know what you're comparing against. Are you comparing it against historical trend? Are you comparing it to some type of control group that resembles your population? And I think one of the challenges in these evaluations has been we haven't had a good counterfactual to compare against. So long story short, and this echoes what Suzanne said, is that the studies to date are mixed. And to try to really understand what's happening in this space, you really have to unpack the results for any particular study to really understand the design of that particular ACO and why you're seeing what you're seeing. And it's very context specific. So context specific in terms of what market the ACO is operating in, as well as the specific design elements. So before I turn this over to David, I just wanted to remind people what types of things ACOs can vary on in terms of their design or structure. So one aspect is the type of financial risk. So a number of ACOs are what they call upside only, which means if there is savings, the payer, the plan, will split those savings with the provider. Some are two-sided risk, where the provider is accountable for any losses. So if they exceed the spending targets, the providers would be on the hook for absorbing those. How savings are measured. So different ACO contracts have different ways of measuring whether savings have occurred. They have different measures that they're implementing to try to tie performance to, as well as measuring savings. They also vary in terms of the type of infrastructure support that's provided to the providers to help them make these transitions to a different way of delivering care. And also, there's a lot of variation in terms of the structure and governance of these different ACO models. So in terms of what providers have been doing to respond in this new environment, they have been working pretty heavily on the data, both in terms of the presentation of that data back to the organization as a whole and to the frontline physicians, and to try to pull together and organize this data to inform decision making. And that has been a fairly complicated proposition, because what you want is that data in real time, not 6 months post. Some of the more sophisticated organizations have been taking that data and trying to do predictive modeling to estimate who's likely to land back in the hospital or to escalate and be more costly and to intervene earlier. They've also worked, as I said, to improve hospital discharge planning, to shift care to lower cost providers and lower cost settings such as ambulatory surgery centers. They've also increased the use of palliative care. So end-of-life care, the care that most patients receive in the last 18 months of care, is one of the largest cost drivers in the healthcare system. And so if you can better transition people through those last 18 months, that can save a lot of resources and be very patient-centered in the process. So I want to now transition to David, and then I'll come back and talk to you about Medicare.
Thank you, Cheryl, for the great introduction and background to ACOs. And I'm going to talk about a specific CalPERS experience, and I'm going to talk about one specific instance as well. I wanted to remind you of three kind of important points to kick off, is that these accountable care organizations are really kind of financial and quality outcomes for a defined population across the continuum of care. And these can exist in a PPO or in an HMO environment. The other thing to remember is that these things, I'm calling them accountable care organizations here, but they often come attached with different names to them. And so it's kind of this broad umbrella of what an accountable care organization is. Again, we started off with this idea of that better coordinated care and health management would lead to higher quality care and lower cost. And you've seen it now 3 times, right? The dramatic growth of these ACOs over time. In CalPERS, that means that in 2017, the Blue Shield population, about 43% of our members were in an ACO environment. And about 59% of our Anthem PPO members were also in the ACO environment. So they've just kind of exploded over time. And we're seeing that within our membership. So in 2014 through 2018, in our HMO contracts and also in our PPO contracts, we have requirements that our plans or carriers expand these, what we've called integrated health management models over time. And that includes expanding to different regions, expanding to different, essentially just grabbing more covered lives into these integrated health models. And this includes things like increasing the use of evidence-based medicine or more electronic health records or patient-centered medical homes. And the idea is that they would continue to iterate these ACO models over time and make improvements to them. And so CalPERS has also been heavily involved in working on ACOs. We've spent a lot of time thinking about measurement. We have worked with the Integrated Healthcare Association on their ACO reporting measures, which came out in 2018. We saw Suzanne earlier talk about Catalyst for Payment Reform. We worked with them on a number of their initiatives, Scorecard 2.0, which isn't exactly ACO, but it includes a lot of the same measures that we would use over time. In addition, we partnered with UC Davis to kind of catalog quality measures, clinical quality measures, to look at what we could use to either monitor or look at outcomes of clinical quality over time. And so now I'm going to talk about this specific instance of the Sacramento Regional ACO. And so Julia alluded to this earlier, that this is kind of one of the largest and longest running ACOs, commercial ACOs. So in about 2008, CalPERS and Blue Shield of California were having conversations about piloting one of these commercial ACOs. And so Blue Shield of California, Hill Physicians Group, and Dignity Health implemented this for our CalPERS members in 2010. So this is happened with those 3 partners had a contractually shared financial risk and savings, and Cheryl alluded to this kind of upside and downside savings and risk, and these contracts actually had both of those. And there were targets set for spending based upon outpatient, inpatient, and pharmacy. There were other categories as well. So if these targets were met, then the parties would share in these shared savings. And so what that means for the CalPERS members, if you were a CalPERS member in Blue Shield and you had a Hill Physicians Group primary care provider, you were automatically enrolled, and you were in Sacramento Region, you were automatically enrolled in one of these in the ACO in the Sacramento Region. And so there were a lot of goals and strategies and expectations, and I kind of wanted to walk through those a little bit here. And we heard a little bit from Cheryl what some of these strategies and initiatives might be. So the three partners, Shield, Hill, and Dignity, the stated goals were to deliver cost savings and then maintain or improve quality of care. In addition, they were interested in growing their membership, and because this was in 2010, at the very start of these kind of commercial ACOs, they were also intent on creating a sustainable model for expansion of these ACOs. And so they did this, they laid out 5 strategies to achieve those stated goals. The first was, again, as Cheryl alluded to, these kind of better data exchange, so facilitating the exchange of patient information. And that was kind of the basis for the rest of the strategies. The next was using this data to reduce clinical and resource variation. So that means if a member presented with a condition, that the amount of resources and clinical treatment would be the same no matter where they presented. The next is managing utilization. So that, again, they would use that data to, essentially this one means coordination of care. So they do a good job of coordinating care across all the 3 members. The next was using that data for personalizing care and disease management. And this really kind of focused on increasing the use of, removing waste and increasing the use of evidence-based medicine. And the last use of that data was on reducing pharmacy costs by targeting. And so that could be targeting physicians, that could be targeting patients, depending upon the case. And so if we get to the purple box over here, these are the sample initiatives. And so they had a number of these initiatives that they were interested in. Some of them were low-hanging fruit, and so they had a lot of these initiatives in each of the category. And these changed over time, depending upon if they didn't feel they succeeded or perhaps that they achieved their success and they implemented other initiatives after that. And I just listed these as examples, but on this last one, so reducing pharmacy costs, one example would be increasing the use of generics by targeting physicians who were maybe not prescribing as many generics as maybe some of their peers. And then lastly, in the red box, is CalPERS' expectations. And so these are pretty similar for whatever initiatives that we have, which is, in this case, better coordinated care, which would lead to improved quality of care, and buying more of the good stuff and less of the bad stuff, and then lowering our spending costs over time. And so that leads to what my group does, which is I have a small research team who tries to determine if what we're doing is being successful or not. And so in 2015, we started on looking at this Sacramento Regional ACO. And what we did was we looked at continuously enrolled members in Blue Shield of California from 2008 to 2014. So this is 2 years of baseline, and then 5 years post-implementation. And there were about 40,000 non-Medicare CalPERS members in the Sacramento region. Cheryl talked about how important it is to have a baseline and then also this comparison group. And so we wanted to compare who was always in the ACO cohort versus those who were never in the ACO cohort. And based upon all that research that we had done earlier and partnering with those other groups, we developed a series of outcome measures. We looked at medical cost, utilization, and clinical quality, and then we also looked at pharmacy cost and utilization. And we put here a rigorous statistical methodology. It's common healthcare economics evaluation kind of methodology. In fact, and as Julia mentioned, we used the methodology that was able to get us accepted into a publication last month in a peer-reviewed journal. So I'm going to cut right to the chase. What did we find? So we found lower overall spending in the last 2 years for the always in the ACO cohort. This was about a 10% decrease in the last year in spending. We also saw hints of improved quality of care. And what I mean by that is we looked at 14 different clinical quality measures of care. And we saw in 7 of those 14, we saw at least 1 year where the ACO Always group had better outcomes. And those were primarily in the preventive care categories. And what's also good to note is that we didn't see any negative findings in that group. So there wasn't a single year in which we saw negative clinical quality outcomes in the ACO cohort. However, we didn't find any differences in the retail pharmacy spending or utilization. And in this purple box, I'm going to talk a little bit more. We did a separate study on this, but there was no differences in patient-reported experience either for the ACO members versus not. So I'm now going to walk you through 4 slides, which kind of I cut to the chase. Now I'm going to show you some examples of what we saw. So this is total annual spending per member, comparing of those always in the ACO versus never in the ACO. And so what this chart looks at is we're looking at the trend of those always in the ACO versus those not in the ACO. So here in the 2010 year, we're comparing the trend for always in the ACO versus 2009, and we're looking at that trend, the difference, with the never in the ACO trend. And so what you want to see here is a negative value, means the ACO, if you're always in the ACO, the spending is lower. And what we see here is in the first year, there wasn't a lot of difference. In the second year, we saw actually increased costs, and if you see those error bars, those are the 95% confidence intervals or margin of error. And then by year 4 and 5, which is 2013, 2014, we start to see lower costs. We didn't see statistically significant lower costs, but we did see it in the outpatient spending, which is one of the underlying categories here. This is, we didn't see a lot of changes in utilization, and this is an example of that. One of the concerns, or one of the initiatives related to this ACO was related to reducing ER visits over time. And this is the yearly trend in ER visits per 100 members by always in the ACO is the orange category line, and then the blue is never in the ACO. And you can see that starting at baseline in the first 2 years that the never ACO category had higher ER visits, and that trend pretty much continued over time across the time period of the study. So if you recall, one of the positive things was that we did see differences in some of the clinical quality measures over time. And this is pretty typical of the preventive care measures. This is the yearly trend in annual percentage of complete immunizations for adolescents by each of those 2 categories, the always in the ACO and the never in the ACO. We can see in 2009, the baseline, almost exactly the same value for those, for the 2 groups. But then it increased in the always in the ACO category over time, and in fact was statistically significantly different in years 3 and 5. Again, we didn't see any differences for the retail pharmacy by ACO status, and here you can see that basically the trends are almost exactly the same. The never in the ACO category cohort was slightly higher throughout the entire time period. You can see this kick up in 2014, which was due to the introduction of the hepatitis C drugs during that time period. And so I now want to take a step back from that. And actually, we heard it earlier from the board members about how important patient experience is to us and to the board. And so what we wanted to know was the members in the ACO experiencing their care differently than non-ACO members. And so in 2017, we thought about this and implemented a survey called the CalPERS Accountable Care Survey in early 2018, asking about members' experience in the 2017 year. And we looked at CalPERS members in Blue Shield and Anthem because they have a substantial amount of our members. We surveyed about 4,000 members who were in the ACO and not in the ACO. And what we did was we used a national standard survey called the California Assessment of Health Plan survey. They have a accountable care organization module, and so we used 40 questions from that survey and those are in about 10 care domains. Again, I'm going to cut to the chase. We didn't really see a lot of differences. Out of those 40 questions, I may be exaggerating the word few here, we saw 2. In 2 of the questions, we saw differences over time, or differences between the 2 categories, sorry. And those 2 categories are fairly interesting, and it was easy to get appointments with a specialist, had a higher rate of people in the ACO saying they could get those. In addition, members in the ACO reported that their provider's office followed up results for blood tests, x-rays, or other tests. So those are the 2 categories we saw a difference. What's also important to note is we didn't see any negative findings for members who were not in the members in the ACO. So we never saw anything. They were either the same or slightly better in these 2 categories. And then these last 2 questions are just kind of typical of some of the other questions that we asked in which we did not see differences, which is a healthcare team member talking to a patient about specific things to prevent illness, or the healthcare team talked with the patient about all the prescription medicines that he or she was taking. And so the conclusions here is we saw lower spending in the latter 2 years, primarily driven by outpatient spending. We did see some better clinical quality measures. It wasn't consistent over time, but it surely didn't see worse clinical quality measures for people in the ACO. We reported the patient experience. Patients reported their experience were similar in most of our domains. I think in 2010, we had really lofty expectations, and you kind of heard that earlier in today's presentations about what kind of things the accountable care organizations could address. But I think where we've landed is what we've seen here is more kind of modest results with some promises those years going out. And maybe this shouldn't be that surprising to us. Time may be needed to see success, and because this is one of the longer studies of ACOs, so there are some models that suggested by the National Business Group on Health. They have some models that suggested that you might not see savings until year 5 as you get all the data integration and all the strategies kind of worked out. So I think that what we will see, to make them successful, there's kind of a continual evolution in terms of strategies, including possibly larger financial incentives may play a role. Also, concentrating on the more impactful strategies would be helpful. And, in talking to our carriers, they continually modify the way these ACOs look. They're constantly trying to adjust their performance measures, making sure they have the right performance measures. Sometimes they've expanded them, they've reduced them, they've changed them. And another important part, again, Cheryl alluded to this as well, is they're really focusing on getting better benchmarking and cost targets to be able to make sure that they're assessing and making the right comparisons. And with that, I'm going to send it back to Cheryl, who's going to tell us about how our CalPERS experience kind of fits in with the rest of the evaluations and the rest of the big picture world of accountable care organizations.
Okay, so thanks, David. So now that you've heard about CalPERS experience, I mentioned that there is another commercial ACO called the Alternative Quality Contract in Massachusetts. And this program has been evaluated in lots of peer-reviewed journal articles published. The plan worked very actively with researchers at Harvard, and the person who ran the alternative quality contract actually was a researcher from Tufts, who really had thought carefully about the design of this program. And this particular program has some interesting features, and I think have contributed to its success. First of all, they entered into long-term agreements with the providers. So these were 5-year agreements that were risk-adjusted, and they set a global budget based on historical claims. Blue Cross continues to pay the providers fee-for-service payments, but what they did is they worked in concert with the providers to map out a trend line of a 2% increase year over year, and held them accountable for staying within that global budget, if you will. And they rolled this program out initially in their HMO population, in part because of the arrangements that they had. And even within the HMO population, or with the providers in the HMO part of their business, they were still paying them fee for service. But these providers already had some level of accountability for a patient population. And since they rolled this program out, they have now expanded it to their PPO population. These contracts are two-sided risk, and what I think is very different compared to many ACO programs that I've seen, and even straight pay-for-value programs, is that they set absolute performance targets with their providers. And this is something that I hear a lot with providers because if you look, say, within the Medicare Star Ratings program or, say, the IHA Pay for Performance program, the benchmarks that they have to hit, it's based on relative performance. And those change year to year, and they are not known until after the close of the performance period. So this creates a lot of uncertainty for the providers in knowing what targets they have to hit. The other thing that Blue Cross invested in heavily was they worked directly with the providers, analyzing their data and trying to spotlight areas of variation in care, and to have very collaborative conversations about ways in which those providers could reduce variation in care, and to have the providers really understand the problem and own it and own the solutions. And so what have been some of the results? So initially, not dissimilar to CalPERS, they actually saw some increases in spending in the early years, but in some of the later years, they have actually seen slower medical spending. Most of the savings that were occurred in the outpatient setting around procedures, imaging, and tests. And if you look at sort of the profile of the money they were paying out in the form of bonus payments for performance relative to the cost savings, in the early year, they actually paid out more than they saved. But by 2012, the balance tipped. And so despite the fact they were paying out bonuses for quality, the savings exceeded what they were paying out. So they feel like they're in the black right now. The improvements in quality among the alternative quality contract cohorts in terms of what their benchmarks were generally exceeded what they saw elsewhere in New England and nationally. I will say the other contextual factor to keep in mind with this particular contract is that Blue Cross Blue Shield of Massachusetts on the commercial side represents 50% of the market. So they have a lot of sway with these providers. So transitioning to Medicare and what Medicare has been learning, I mentioned that in the Medicare program, there are a variety of different types of ACO contracts. Some that were upside only, which is what the Medicare Shared Savings Program started out as. And CMS is hoping to transition the MSSPs into two-sided risk eventually. There were pioneer ACOs who took two-sided risk. I would say the pioneer ACO experiment did not go particularly well. There were a lot of dropouts by year 3, and I think providers really had a hard time trying to figure out how they could save money in those out years and not get penalized. The other issue that was in play with Medicare, and this has been a source of ongoing criticism, and I think there's a hope that CMS is going to change its policy, is they kept readjusting the benchmarks in the regions. And so providers really had to, they thought they were tracking to a particular increase year over year, and then the benchmarks shifted. And so it made it harder for them to figure out, what they could do to achieve savings. And so this has also led to concern by providers about potential participation and has led some ACOs to drop out, particularly the high spending providers, which are the providers you want to keep in the program. So you have to kind of be mindful of these benchmarks and what you're comparing against and how you're trying to incentivize these providers. But interestingly, they didn't really see much improvement in hospitalizations. They actually saw increases in hospitalizations. And some have surmised that maybe those were needed hospitalizations to better manage care for those patients who were particularly complex. And not too dissimilar to what David talked about, there really hasn't been a whole lot of change around pharmacy in terms of medication use and adherence. So, I would say that the story on the Medicare front is there have been savings. They've been relatively modest, but I think we are still in the stage of experimentation, modifying the design, trying to fine-tune it to get to a place where we achieve better savings. I also think that something to consider here is that the challenge in healthcare and trying to make changes is that oftentimes people come in with strategies and only stay with those strategies for a couple of years. But think about your own organizations and how hard it is to create change. And you really have to be in this game for the long haul and to make deep investments and have sustained leadership and engagement. And so I think one of the critical issues that I point out here related to ACOs is that when I look in terms of the research I do in healthcare around how organizations get to be high performing, I cannot tell you how much leadership change is going on in these organizations. And it's hard for them to stay the course, whether it's on ACO implementation of health IT in their organizations, reductions in variation, and so on. And so all of this contributes to disruption in program implementation. The other thing to highlight is the lack of infrastructure that these organizations have to support the kind of care delivery changes that we want to see happen. And so that type of infrastructure investment is required at the front end to help enable what we want to see happen on the back end. The other thing that I think we recognize as a particular challenge is how to navigate changes in the context of virtual systems of care. So while we have Kaiser, which has a very centralized operation, in the rest of the state of California, you're essentially dealing with these virtual systems. And overlaying the plan and the providers and the physicians and the hospitals and all the other providers who are in this virtual system and getting them to coordinate and share information and act as one, continues to prove challenging, whether you're in an ACO environment or outside. I've already talked about problems with real-time data sharing, and anytime you engage in care coordination, this is cumbersome and time-consuming and requires real investment by the staff within these organizations. So some of the issues to consider in terms of thinking about their potential success is trying to strengthen incentives. And those incentives don't necessarily have to mean putting in place downside risk. I know Suzanne DeBanco talked about trying to push more in that direction and trying to encourage providers to take risk. So while in California providers have more experience taking risk than elsewhere in the country, I would say that in many cases they don't really have a good understanding of how to do that. And it's not to say we shouldn't experiment in that area, but I don't know that that's where some of the savings are going to come from in the near term. So one could potentially strengthen the upside part of the equation by allowing providers to have access to more of the shared savings, to create greater incentives for them to participate and engage in the activities we want them to. I've talked about investing in quality improvement. But there are other kinds of important things that are in play. So this is a cultural shift for most organizations, and it requires a change in the perspective of not only their leadership, but the providers within them. So I just want to leave you with, I think the jury's still out on whether this is a successful type of strategy to implement. I think you as purchasers offer the opportunity to continue to push on innovations in both healthcare redesign, delivery, as well as changing the incentives in the system to try to drive value improvements. And so you have to stay at the table and work with these providers to get them to change. And the providers that I've actually spoken to actually want the purchasers at the table. They want to see these change happen in their organization, and they feel like there needs to be an outside force pushing them in that direction. And I would say that ACOs represent only one of many interventions that should be pushed to try to change what organizations are doing. There's a handful on this slide, but as we continue to develop new technologies and new ways of thinking about how to pay providers, the list of flowers that will potentially bloom will continue to grow. And I would assert, in closing, and I actually haven't read I don't know if I've got the final version of what was accepted at the journal, but as you think about value, the way value improves is either you are paying the same cost and getting better quality for that spend, or you're spending less for the same amount of quality. And if David's data are right, it sounds like you're spending less for roughly the same amount of quality or slightly better. So I would assert that probably the value proposition has gone up.
Thank you so much, Cheryl and David. We really appreciate your expertise and your thoughtful analyses. Mr. Jones, we had a few questions to start the discussion, but in the interest of time, I'm happy to hand it over to you for questions.
No, go ahead, because I don't see any questions from board members, so
Sure.
proceed. Ramon, okay. Mr. Rubalcaba.
Thank you, Mr. Jones. Thank you for the presentation. It's very intriguing seeing the study. First, I do want to commend CalPERS for conducting the ACO study. I was not aware of that, so that's very good. And one of the findings was that there was an increase in spending per member in the initial years, but yet another slide showed that there was also increased blood tests and medical tests and specialty appointments. So I wonder if that could be aligned, meaning in the initial, I don't know if it coincides the study with the beginning of the ACO, so maybe at the beginning there was a need to get assessed and try to stabilize the population. So just speculation, I don't know if you want to comment on that. Then I have one more question.
So unfortunately, I do it again.
It's because this one's
So unfortunately, the patient experience study didn't overlap with the study that we did in terms of the utilization and healthcare quality, and so you're correct. That would have been perfect to do at the same time, but unfortunately that's not what happened in 2010, 2011.
I'm glad you did the study nonetheless, so that's value. The second question is, the findings did show there was some modest savings towards the end. So that raises a question. The ACO is embedded within the larger network. So how do you ensure, I'm not sure whose responsibility it is, but how do you ensure that that savings doesn't get diluted to the whole network or to the carrier? And then one of the stated goals was to increase and to grow the membership. I'm not sure if it's for the carrier or for the medical group or for the ACO. So how do you incentivize? I mean, how does one ACO or medical group say, here we did this, but yet everybody else is reaping the rewards? Or how do you promote more membership to the ACO when you can't produce those transparent? I mean, when Ms. Taylor talked about the real costs, I mean, those are not shared. So that's a challenge. I was wondering if that ever got discussed in any study, any place.
Yeah, so I think your first question is that the idea is that that savings comes back to us in terms of our premiums. Our premiums end up being lower because of that savings that came to us. So it is diluted amongst all of, say, the Blue Shield premium or in the Sacramento region. So that is the case. In terms of the more membership, so Blue Shield's goal, and Hill and Dignity's Health, was to try to get more of our membership. At least that's what I meant by they wanted more of our membership. And then also that second part was to expand that model out to other regions and other health providers and hospitals throughout the state. And in fact, as we've seen, 43% of our membership is now in a Blue Shield ACO. So that has in fact happened. They've kind of created some sort of model to grow off of.
Thank you.
Just to follow up on that, so CalPERS is unique in the Sacramento region, with such a large population. But in the work that I've done, because I interview physician organizations and healthcare systems, and I ask them if they're participating in an ACO, and most of them say yes. And then you ask them, okay, of the total population of patients you see, what fraction of your patients are in ACOs? It tends to be extremely small. And I think that this may be one of the contributing factors to why we're not seeing larger effects. And I would encourage employers, purchasers within communities to try to work together to try to increase the presence of ACOs within any given health system or physician organization. Because if only 3 to 5% of your patient population is in this arrangement, and yet you're dedicating a lot of resources to trying to have to change up care processes, what's the likelihood you're going to make that investment on 5% of your population? And so I think there's probably a tipping point in here to try to push enough of the market into an ACO type arrangement where providers will sort of sense there's enough traction and enough value there to play. I routinely ask providers, like, what fraction of your total set of revenues are value-based? And they'll tell me 1-2%. So that's the problem we're still dealing with.
Thank you. Thank you, Mr. Jones.
So I see no further questions from the board, Dr. Logan. So do you have anything else at this time?
Yes, let me just advance the slide. So we did have just a couple questions, and I know Cheryl and David, you touched on these during your presentations, but if we could hear from you about, did the ACOs, or do ACOs meet their original promise of value and increasing the value of every healthcare dollar? Is that something that you guys could discuss? And then as an add-on to that, what is the future of ACOs in the marketplace?
So maybe kind of answer this. I mean, we kind of answered a little bit of this in our presentations, I think. And so, but last Friday, an article came out in JAMA on ACOs, and it included some information related to, it was kind of underwhelming, the success. And there was an editorial attached to it, which talked about there are things that are being done in the ACO that you wouldn't stop doing just because you're maybe not seeing success, like pharmacy reconciliation. So, doing those things seem logical to improving the quality of care, and it may not make a big enough dent in terms of seeing these final outcomes, but there are things that you still would do just as part of evidence-based medicine or whatever strategies to improve people's health care.
Yeah, I think I sort of think about ACOs as part of a larger constellation of interventions that we're trying to apply to change the market dynamic. And so when you think about the future of ACOs, will they look like the first ACOs that came out of the gate? No, I think we have a better sense of how to design them differently. And I think if you kind of really dig into some of the experiments, so we know that physician-led ACOs tend to perform better than hospital-based ACOs. And I think if you can try to extract some of those pieces of information, as well as think about some of these design elements, I think we could get to another generation of ACOs that might perform better. But no matter what, we're still facing very strong headwinds from what I call the fee-for-service, profit-maximizing environment that any of these interventions function in. So I think the sooner we start moving some larger aspect of how we pay providers to things that look more like global budgets, where you're really holding them accountable for the total spend, I think that's the path we need to be on, and it's going to come through a variety of mechanisms. But when we all sit down at the table and we continue to pay them fee for service, we're not getting any traction. And I would also say that I think there have been certain policies that have been put in place that have had some unintended consequences that we've observed over the past decade. So while Medicare shifted in the direction of not paying for readmissions to the hospital, and hospitals were sort of looking into this space and seeing fewer admissions, fewer beds filled. Their response was need to increase the flow into my hospital by buying up more practices and controlling more of the market. So to some extent, a lot of the consolidation is driven by these policies that are putting downward pressure on the amount of revenue that's going to be secured by providers. And unfortunately, what we haven't seen is what I would call the counterbalance to that through regulatory mechanisms like the FTC. So as we think about some of these policies and whether or not they've resulted in good things or bad things, we need to learn from what's happened to try to design better policy making in the future. I would say that ACOs have really changed the dynamic in many organizations. So from, did they meet their promise? Well, maybe they didn't meet their cost savings targets across the board. But I do think that they got providers and health plans talking in a very different way and working to do the kinds of things that we think would be evidence-based care. So from that standpoint, I think that is a success.
Okay, is that it? Questions from board members? Okay, well, thank you very much, Dr. Logan, Dr. Danberg, and Dr. Collin for that informative presentation. So now we'll move away from healthcare, and we were scheduled to move